So welcome everyone. We're trying to decide if this is like the lull in the afternoon where people are starting to lose the momentum or if the excitement continues. I'm pretty sure the excitement continues. So welcome. Our session today is called The Value of Social Prescribing in Clinical Practice. We've got 3 physicians here with us. I just keep seeing that like people keep entering the room, so I'm just I'm going to stretch out the intro a little bit. So okay, so welcome to our session. If people have received their conference packages, maybe you're sipping tea or nibbling on chocolate, I hope. And so the seed for this session came from 2 questions that I get frequently asked. So very frequently people ask me, I have a social prescribing program and I'm having a hard time getting referrals from clinicians. Well, how can I engage clinicians to work with me? And then the other question I get on the other side, but less frequently, but still sometimes I get this question. So I'm a doctor, I'm a nurse practitioner. I'm looking to start doing some social prescribing work. How do I get started? So those were kind of the 2 questions that were coming up a lot. So that was sort of the seed that sparked this idea to have this session. So we have an amazing panel today of 3 physicians working in 3 different settings who have lots to share about their take on social prescribing. So I see more people are filtering in, so I still feel a little hesitant to dive in fully, but I guess we can start by getting started. So I'm going to start off with just introducing ourselves. So who am I? We'll start with the question, who am I, and what does social prescribing mean to me? And perhaps even an example story. So I'm going to start with Dr. Dominic Nowak. So if you'd like to go first and with some introductions.
Thanks, Natasha. It's my pleasure. So I'm Dominic Nowak. I'm a family doctor in the Greater Toronto area. And the lenses I bring with me in social prescribing are actually mainly as an early career physician. And why I say that is, I think what led me originally to social prescribing was actually this deep sense of frustration. And it's this deep sense of frustration between what is versus what could be. And I'll explain what that means. When I was in residency and training, and we had this fabulous team at the Mac family practice in Hamilton, and we actually had a systems navigator there who could navigate some of the social needs that the people in our practice experienced. And that was fabulous. And actually it was both enriching to me as an emerging family doc, learning there from this person. It was good for the people that I was caring for. It was just such a win-win-win. And then so that was the what could be that I started with understanding. And then suddenly, after you finish residency, some folks here may know this from personal experience, you're thrown out into the real world. And in the real world, a lot of practices don't have such a thing, right? So when I moved to Toronto, not only did I have to learn a lot of the social care and healthcare system itself, but I didn't have someone like Dan, right? Someone like the systems navigator there. I had to do some of the stuff myself. And I realized that actually it was really hard to do, right? So what social prescribing is to me is making that bridge real, right? And making that bridge real in not just some places that have, systems navigator or link worker already, but making that bridge real everywhere, including for docs like me who usually practice in solo settings. So far, that's the lens I've been practicing in, mostly up until this point. So again, I think that's where we need to think the what is for most family practices and clinicians, and what could be that amazing environment where we do have these links to social care, and that's enriching for all sides. And I have a ton of stories on this. I'll come back to the story, I think, in a future question. But with that, I think I'll just hand it off to the next person.
Great, thank you. So how about Dr. Gary Block next?
Hey there, thanks, Natasha. So I'm Gary Block. I'm a family physician in Toronto as well, although I work in a very large multidisciplinary team with St. Michael's Hospital. It's called the St. Mike's Academic Family Health Team. I also work with a group of healthcare providers who work in homeless service settings called Inner City Health Associates. And I mean, I've been in practice now for, I guess, getting close to 20 years. And the sort of question about what we can do about social risks to health on the front lines of healthcare has really been a driving force for me in kind of how I think, well, really how I think about where I want to go with the way I practice, and also hopefully with where we've gone over the last 10, 15 years that I've been in practice. And you know, I really appreciate the fact that Dominic talks about wanting to sort of create a bridge with social prescribing. And I think I very much have seen this in the same way, although I would probably frame the bridge slightly differently, although I think it's maybe similar when you kind of dig down. But I often say there's like two big pieces that have pushed me into this work. One of them is just sort of, you know, wanting to respond to the evidence, and the evidence that we know links social risks to health outcomes, you know, and adverse social risks, obviously, to adverse health outcomes. I mean, it's a huge body of evidence. I could spend all day talking about it, you know, but the question for me has always been, well, we've known about this body of evidence for hundreds of years, literally. Why aren't we doing something about it in frontline practice? And then the second big gap for me is the gap between, you know, what my patients tell me their real health needs are and what I am trained to see as their real health needs, right? And you know, and to me, that is all about just sort of listening to people, listening to their stories, listening to their perceptions, and understanding of what they feel they need from healthcare providers, and starting to respond to those in very real ways. And so if I'm going to talk about a bridge, it really is a bridge between those elements and, you know, what I think healthcare practice could look like. Yeah, and I have a lot of very specific examples of how we have tried to build that bridge, which I think we'll get into later in the conversation. But I do want to say that for me, this is in some ways a simple practice, right? I mean, the name social prescribing lends itself to this idea of like a very simple, you know, I write a prescription for you to do something that deals with a social risk to health, boom, it's done, right? That's fair, but on another level, it is incredibly complex, right? It is complex in the sense that we are opening up our understanding of health to include a whole other arena of, in fact, a whole other interpretation of what health is and of what healthcare is and could be, right? And that's an interpretation that says that we see the social as central to people's understanding of their health and well-being, and also that we are willing to be critical of our space or our place in that journey towards health and well-being, right? And I think that when you really dig down into what this concept of social prescribing could be at that deeper level, it becomes A, a more complex entity, and B, a more challenging entity to how we see ourselves as health providers and a healthcare system. You know, dare I say, a revolutionary entity, right? And again, I'm happy to sort of flesh that out later because this is only the intros, but I'll kind of leave it there. And I'll also, like Dominic, save my patient stories of great success for later on, but hopefully that gives just a bit of a sense of kind of where I'm starting from in this conversation.
Great. And we'll pass the mic over to Dr. Lawson.
Thanks, Natasha. So yes, my name is Jennifer Lawson. I've been practicing family medicine for almost 15 years now. I work in Thunder Bay, Ontario. So right now I work at Norwest Community Health Centers. I've been here for about 6 years. And I just wanted to start to give by giving people a little bit of information about where I work, because I think in terms of social prescribing, We have done very well. I'm very, very proud to work at Norwest Community Health Centers, and I enjoy my practice here. And I think a large part is because we do so well with this social prescribing piece. So first off, my patient population, we have lots of patients that struggle with addictions, poverty, mental health. We do have a large refugee population. We service a large LGBTQ plus community. We do gender affirming care, so a wide variety. We have an amazing amount of providers and services. So there's physicians here, we have nurse practitioners, we have a psychiatrist who comes regularly to the clinic. We have community health workers, and those are our links, and those are the individuals who help us to carry out our social prescriptions, and they're so valuable to us at our clinic here. We also have access to dietitians, to foot care. There's an FASD, or fetal alcohol spectrum disorder diagnostic clinic. And so this is all housed under one roof, which is amazing. And we also have a lot of programs here. So again, housed under Norwest is, we have good food boxes, we have arts and crafts, we have cooking classes, we have smoking cessation and knitting groups, depression, anxiety groups. I could go on and on and on. So I think you get an idea of the amazing amount of resources that I am so lucky to have access to. In terms of what does social prescribing mean to me, I feel like for me, it's meeting patients where they're at. So I may have an agenda at the beginning of each visit, and a patient may have an agenda at, from their perspective. And I think unless those two agendas align, then nobody's really going to be happy with their care. So it's finding that common ground, and so that everybody is happy with how things move forward. I really try to look at my patients from a biopsychosocial perspective. So obviously putting, I think it goes back to our social determinants of health, and putting everything, looking at the whole patient, and obviously doing that, providing better outcomes. So I also have lots of patient examples, but I'll hold on tight to them too, because everybody else is, and I'm sure I'll get a chance to talk about them a bit more later on.
Great. So yeah, 3 physicians working in 3 different settings. And maybe I'll just share a little bit about how I came to social prescribing. So I work at the Alliance now, but until recently I was a health promoter at Centertown Community Health Center, a long time serving health promoter, where I worked in smoking cessation, physical activity, stress reduction. And when I was asked to take the lead for social prescribing, like when I first looked it over, I kind of, I had a similar reaction a little bit to what Dr. Lawson is sharing. This is similar to the work we're already doing in our community development, in our health promotion. And what I liked about social prescribing is taking that work and making it a little more intentional. So instead of just me saying, oh, you should come to my stress reduction group, it's like the clinician who has that long-term trusted relationship with the client says, Natasha runs the stress reduction group. Like, it has a bit more weight, and also because the clinician, you know your clients best, and then just making those referrals really easy, to make those referrals from clinical to non-clinical programs, making it easy, seamless, having those intentional referral pathways, and then like measuring some of those outcomes and being able to give feedback back to the clinician, like, oh wow, your client came for their annual checkup and their anxiety is so much more reduced. So the checkup was able to be much smoother because we were able to really focus on what we needed to do in that session, just as a quick story. So yes, I'm not a doctor, but I've been on the other side, and I've worked with some amazing clinicians who have been great partners in this work. Yeah, do we want to dive into a few examples? Ready for yours or should we go through some of the questions?
Natasha, I just wanted to emphasize something that I heard you share that I think is very important for the group to hear and reflect on. Is it's taking the work that's being done and making it more intentional. And I think by doing that, by calling it a social prescription, or calling out that it's an intervention that addresses social needs, it actually does not that it needs to be legitimized, but it actually does a lot towards legitimizing it and makes sure that we are doing this and looking at these domains intentionally as, you know, as clinicians and doctors, but then also following up on them, tracking them, and that we're actually giving them the same kind of weight as medical prescriptions or medical referrals, because at the end of the day, you know, like Gary said, actually most of health is related to the other stuff, not the pure clinical sciencey medicine, as you know, I might call it. It's actually the social determinants, and I think that's just something that I heard you say that I really loved, and I wanted to share back with the group.
Thank you. Well, maybe, oh, go ahead, Gary.
Well, I don't know if you want to open this up, Natasha, but I just wanted, can we just go? All right, it's the beauty. It's a fireside chat, right? So here we go. Yeah, so I wanted to sort of talk a bit about, like, I do value the idea of social prescription. I think it's something really, really powerful, like as Dominic just described, and really easy for us to kind of grab onto when we talk about social prescribing, right? It fits very easily into sort of models of care. And I think it's really important that as many of us as possible start doing that type of work, right? Start finding ways on the front lines to, you know, first of all, identify what patients' social needs are, and second of all, start finding bridges into benefit programs, other community agencies, you know, whatever's kind of, and within our practice, whatever's able to kind of address those needs specifically. And that work should be done urgently and should be done right up front. What I will also suggest, though, is that in order to do social prescribing really well, we also need to kind of look backwards a little bit, right? So I see the prescriptions as being sort of a very outward-facing piece. It's like, I write prescription, give it to you, off you go, right? And the backwards-looking piece, which I think, again, comes back to this idea of like really digging more deeply into what it will take to entrench a social approach to health, that involves a number of pieces, right? It involves, first of all, challenging ourselves and the way we practice and the way our institutions are structured to allow for to allow space for these social needs to come through, right? And that means a lot. That means dedicating resources within our practices. It means dedicating time within our interactions. It means truly advocating for funders to support this type of work, right? There's a lot that goes, and it also means actually asking our professions to value this work, right? So that we feel like we are not just sitting on the margins all the time, that this is kind of coming to the center. So I think that's one piece of it. I think another piece is doing some really deep reflective work, right? Around the fact that as much as we like to talk about addressing social needs and addressing inequities specifically, that our institutions, our professions, and, you know, depending on who we are, but in many cases ourselves, are intimately tied into the structures that have created and continue to create those inequities. And so I think some of the backwards looking work, and maybe backwards is not fair because it really is very forwards looking work, but some of the inwards looking work, I should say, really needs to focus on building an understanding of our place within those structures of power and privilege, and just institutional memory and just organization that have led to those those really huge health inequities that we are trying to address through these types of programs. So just to offer that up.
Yeah, some pretty deep thinking, some deep inward thinking. It kind of goes back a little bit to what Jen said about, you know, being client-centered and listening to what the client needs. And sometimes that, yeah, that might need quite a bit of self-reflection.
I heard that in the last session as well, that I think one of the speakers said that, especially in the mental health care system, but then generally in the entire healthcare system, people's experiences are not always positive, right? So sometimes social prescriptions, the most effective ones, or the most effective social interventions, are outside of healthcare. And what this means is that people have different bridges that make sense for them to social needs, and that's different for different people and different for different environments as well.
Yeah, like I can just give an example. I would promote free activities to my clients at the community health center, like going to the museum on the free day, a few blocks from where my clients lived. And they were like, I've never been in there. I've lived downtown all my whole life. So it's like we would do group field trips to go to the museum with like the trust, like they knew me, they knew the health promoter. So I'd say, I'll meet everyone outside, we'll go together. And then once they got, so sometimes even just building trust with a new organization, even something that's that's open to everyone, people don't feel welcome there for whatever reason. So building some comfort and then once, I think we did our walking group in the National Gallery of Canada, which was a place no one knew where it was. No one had ever been in it. They had lived downtown their whole lives. And then they started to feel like they were regular, welcome at this place. And they started going on the free time. And that's interesting how people can feel comfortable and feel welcomed at a place, but they might need a bridge, as you mentioned.
Yeah, I'd like to share a patient example as well that I think fits in with all of this. I had a young woman, she was about 25. She has a history of a mild developmental delay and an FASD. She also struggles with depression and anxiety, and then also has type 2 diabetes, high blood pressure, dyslipidemia, and whatnot. She was what you would call a frequent flyer to Emerge. I think we all have a few of those patients. And she was going to Emerge, 2, 3, 4 times a week for various reasons and, minor ailments. So fell, hurt wrist, query urinary tract infection, those sorts of things, which you would maybe say don't quite require an emergency room visit. And there was lots of concern, lots of red flags raised, not only from the emergency department, but from our clinic and trying to get her to, not go to the emergency room as much. And this had been going on for quite some time. And, a lot of time was spent talking to her about what's appropriate and what's not appropriate in terms of use of the emergency room. And we talked about other things. Could you use a walk-in clinic? And in any case, eventually this patient was set up with some of our community health workers. I continued to see her in my office, and through more discussion, and I think this goes back to talking about what the patient's needs are and whatnot. We sort of looked at the pattern of the Emerge visits, and they were almost always in the evening or overnight. And it came out that her anxiety was the worst in the evening and in the middle of the night. And she was very lonely because she lived by herself and felt that most. And when she went to the Emerge, everybody knew her name because she was there all the time. And it ended up, we figured out that she was lonely and she was anxious, and going to the Emerge was actually a place where she felt comfortable because people knew her and she had people to talk to. And so once we finally figured that out, we could actually address what was sending her to the Emerge all the time, which was the anxiety and the loneliness. And we connected her with our anxiety and depression group, and we got her a support worker through Alpha Court here. And we got her involved in a cooking class, which was great for socialization and also helped her type 2 diabetes. And lo and behold, guess what happened? Her Emerge visits went down. So I think it's such a great case for showing that you really need to, dig deep and figure patients out and what really that underlying issue is. And it was such a great result after, it took some time, but such a great result after we figured that out.
That's such a great story. I have a very similar one from Centertown. As someone in long-term palliative care, housebound senior would page our physician every Saturday afternoon because the home visiting nurses only come Monday to Friday. So this physician would send her to emergency every Saturday afternoon based on these feelings of anxiety and racing heart. And we started realizing it was because of loneliness was one of the main causes. So we set up a nurse's call, a check-in call Friday afternoon. And then we eventually shifted to volunteer check-in calls. And so what a great cost saving for the healthcare system if we can get to some of those underlying needs. Oh, people are saying they're having a hard time hearing me.
I can hear you well.
Okay, sorry.
Yeah. The loneliness conversation is really interesting because I think that's especially one where this was shocking to me as, you know, as early in my training and everything like that, thinking of medical training. Oftentimes we think of what's wrong with this person, right? As we think of deficiency, we think of what are their needs. But actually, if you think of loneliness, a lot of the interventions that actually benefit loneliness could be based in the person's strengths, right? And I hear that when I see groups like volunteer groups tackling loneliness, where the person that has that social need is actually giving back with using a strength of theirs. And that was actually profound to me when I realized that could be a thing, and especially coming from the medical model, where our focus almost always is on what's this person lacking or missing, or what's wrong with this person.
And that was where we saw some of the greatest benefits, was when people stepped in to volunteer and like felt like they had something to contribute and give back, no matter how small the volunteer role was. That's where people really talked about their self-described mental health as vastly improving and having that sense of belonging and the decrease in isolation.
I just want to say, like, I mean, the stories are amazing. And I just noticed that, like, you know, both Jen and Natasha tell these stories with like smiles on your faces, right? Like, these are happy stories, the way these things come together. And I mean, this has always been my experience as well, right? Is that this work feels very good. It feels like you're actually kind of dealing or supporting patients who have not been well supported and often have had years and years of frustration in the system. I just want to say that there's sort of a really interesting, relatively new literature that shows that engagement in social prescribing and social interventions in general actually improves clinician satisfaction and reduces burnout amongst clinicians in primary care settings. And I think what we see here in these stories is exactly why that is. Like, it's actually, I mean, it's surprising. It's surprising in some ways, because often the questions I get are, how do I possibly fit this work into practices that are already overloaded, right? Like, there's just no space for this. You've got to be kidding me. But it's, you know, and yes, I think that's true. I think all of us are kind of, especially now with COVID, all of us are kind of burnt out and overloaded and feeling pressures. But the flip side is that when you start doing this work, you actually feel better about the work that you're doing, number one. And number two, I truly believe, like Jen's story points to, that you reduce work on the road, right? You take burdens off the system because you're dealing with upstream determinants of health, which should reduce that work later on. So I just think that's a really important piece to put forward.
Yeah.
I couldn't agree with you more, Gary. You know, I think I have lots of challenging patients where I work at, yet I continue to love what I do. I feel like social prescriptions are like a happiness raise for me. You know, it just improves so many things, and definitely prevents that burnout, and just makes me enjoy what I do. That satisfaction factor goes up, and I think it enhances the patient-physician relationship, which again just provides for better care and better outcomes.
I felt that too, just echoing what Jen shared. I do want to share, so this is going to maybe the spicy part of the talk. I've seen articles from primary care professionals, leaders that have said social needs, not our cup of tea, not our domain, right? This is beyond the scope of medicine. This is not something we should be doing. And I obviously disagree with that, but there's a reason for that as well. And I think it's important to acknowledge that reason too, and that the stories that people have around addressing social needs are not always happy. Actually, social needs can be very tough to address. And a lot of practices are not connected with link workers or systems navigators, or this, you know, future state that all of us, I think, hope will be the case. one day. And I don't want to end on a negative note with this comment. So, and yeah, there's a way forward, and I think there are these informal supports even that are coming up, like 211, like the Ontario Caregiver Organization, like many other resources that people can draw from to get back this, both the being a better doctor by social prescribing and by addressing social determinants, and then also the joy that comes from that, from seeing someone where they're at, and from actually doing medicine well. And doing medicine well means also looking at the social determinants and looking at a person's social needs. So I think there's a way forward, but I do want to acknowledge that this conversation is not always a happy one in clinical practice. And in fact, what brought me here to this group in the first place was being very frustrated at being in the community after training and alone, and not being able to have these same kind of supports and working with people in the way that I wanted to, and not having the time to do it as well, especially in a fee-for-service practice.
So yeah, we have 3 different models here. We have a solo provider, we have someone in an academic family health team, and we have someone in a community health center. So 3 different ways of working, and how can we make social prescribing work in each setting? Like I will say, I'm gonna, oh, go, sorry. Go
I just saw a chat message about link workers and systems navigators, and asking, do we need link workers and systems navigators in primary care for people to do social prescribing? I think the answer is no. People can do social prescribing without these supports, but it takes a team, right? I think social prescriptions are so much more effective when you can lean on a team, when you have these kind of supports who know your community well, and then you can work with as well. So I think there's an ideal state, and then there are maybe some social prescriptions and things that we can do even in solo practice without that.
Do you want to share a story of how you do that, Dominic?
I saw Gary wanted to share, so maybe I'll follow up after Gary's share.
No, I just wanted to say that at its simplest core, social prescribing is about being able to identify a social need and have some sort of intervention to deal with it. That doesn't require a team. It doesn't actually require very much time, right? It sometimes requires a very simple set of questions around someone's social situation, which I think we are trained in general as primary care providers to ask those questions anyways, right? And we've sometimes sort of downgraded them largely because I think we often don't know what to do with the answers to them. So we don't really want to, kind of don't ask, don't tell kind of approach. But if you start building up even a simple set of resources, where someone says, yes, I am living below the poverty line, you have some sense of okay, I know a little bit about income security resources. I know a little bit about food security resources, et cetera. Someone's living in substandard housing, a community agency that is helping people access housing supports, et cetera, right? And there are many, many, many examples of where that could go. It takes a few minutes to add that on to what you do. No question, you get more impact with a bigger team, right? But not everyone has access to that at all. And I would say do what you can within the space that you have, because it is really powerful. And then I actually believe that, and this is a large reason I engaged in this in the first place, that I think this stuff kind of mushrooms, right? I think that the more we sort of crack open the door to this, the more we as a collective stop being able to kind of turn away from these realities. And actually, there was a question that came through which said, do you think social prescribing could be a way through which we can advocate for more systemic change, like reducing income inequity? And I do. And I do for 2 reasons. First, because we are able to have a far deeper understanding of people's lived realities that we can then carry forward to conversations with people who make social policy. And number 2, because the more of us that do this, the more we build kind of communities willing to push towards the sort of systemic changes that are needed, right? And very powerful communities of health providers who have respected voices. So to me, this is 100% a starting point towards those type of systemic changes.
And Natasha, that I love that share, Gary, because it launches into my story, I think, really nicely with the start where you are, use what you have, do what you can kind of approach, even in solo practice. So I'm thinking of a few years ago, I was filling in for another doc. Imagine this rickety office, walking up the staircase to the I think 1 or 2 office rooms with a receptionist as well in the office, and I'd seen someone for a diabetes visit. Now it was a few months apart, and for whatever reason, their diabetes was getting worse all of a sudden. And we were thinking of, I was thinking of all the medical options and different medications that we could add on to their already exist. So they're already treated for diabetes, but add on beyond that. And I just went, 1 or 2 questions further. And during that second or third visit, asked, is there anything else that could be going on? And is there, what could be happening here? And it turned out that their dad, it's actually pretty young, otherwise had been hospitalized a few months before, and they were now all of a sudden doing 5 or 6 hours of caregiving per day. And no wonder their diabetes was getting worse, right? And I would have missed it had I not asked that 1 or 2 extra questions, because these are things that sometimes people don't share if you take a purely medical approach to the visit. And we were about to start this person on a medication when instead, actually what we ended up doing was there were a few different community supports that I helped them navigate, but one of them, a main one, was the Ontario Caregiver Organization Caregiver Helpline. And long story short, they helped the person navigate this entire situation, have some community-funded supports for that caregiving, and that was what made their diabetes better, rather than adding another medication. And that made me a better doctor and allowed me to be a better doctor for that medical issue. But also it let me see what was actually going on in this person's life that was contributing to their diabetes and contributing to their health. And that was in a solo office, just me and the receptionist, up a rickety staircase with barely a computer, a functioning computer in the office. So you could do something anywhere. So start where you are, use what you have, and do what you can. That's the bottom line from that story.
I think that's such a great story, Dominic, and goes to show, even like you said, if you're in solo practice without a lot of resources, just asking the questions is a start at social prescribing. And something that I learned during my training and I use to this day is the concept of fifing. And I'm sure Gary and Dominic have heard all about fifing. And so for everybody else, it's F-I-F-E. And it's something that we learn in residency of questions to ask patients. And so the first F is feelings. So what are your feelings about this? The second I is, oh gosh, now I'm blanking. Ideas, sorry. What is your idea of what's going on? The third one is function. Has this affected your function? And the E is expectations. Do you have any expectations for this visit? And I think these 4 questions really help. Sometimes you have those patients you just can't put your finger on. You feel like you haven't connected. And sometimes just going back and asking, even if it's 1 or 2 of these questions, really helps to get you on the same page. And I really use this lots in my clinical practice. And I find that it often, my social prescriptions sort of go off on that stream, depending on what the patient's answer are.
You know how they say you have a flock of geese? But then the one for family doctors is you have a fife of family doctors. That's the inside joke on fife.
Love it. I also think when you say like start small, like one of the things we did was we got free family passes to go to the museums, and we gave them to all of our clinicians, and they could just hand them out whenever they felt like it. And the feedback I got just when we were talking a little bit earlier about like raising the happiness level, like, my clinical colleagues would say, I have these appointments and I'm like, okay, you have to eat less salt and you have to exercise more and you have to quit smoking. But I also have these free passes. Would you like them? And it was just such a nice way to end the visit with like being able to give something instead of always being like, trying to change behavior. And that could be a nice little touch.
Or a referral to a free community income tax clinic, which, believe it or not, can be transformative to someone's income. So many little ways, and it's the same thing, right? It's one phone number or an address and it's on its way, but I've seen people's income literally more than double simply by filling out their income tax forms and accessing benefit programs they were never getting.
Yeah.
Gary's being humble, but shameless pitch for his amazing TED Talk from a few years ago on this exact topic. I hope that's okay, Gary.
So I don't know if we should tackle we've got some great questions and comments in our chat. I don't know if we should start tackling some of those. I know one of those questions is, well, there's a couple questions I have here on my list. So what are some specific resources or people you draw from? Has there been a surprising benefit to social prescribing in your practice? My colleagues are going to say, how do we engage with these clinicians? And I can also go through the chat and pull some of those amazing questions out.
You know what? At the end of the day, it's social prescribing helps me be a better doctor. Social prescribing helps me be a better doctor. And that's, again, regardless of where I am, it's that use what you have, start where you are, do what you can. Sometimes what I use is just Canada 211 or Ontario 211, honestly, and looking at they actually have a referral system and some resources that for clinicians, but sometimes it's just knowing some of those global resources that you can use, like 211, like the Ontario Caregiver Organization, like the Older Adult Access Centers, and so on, and knowing some of those in your community, and then also provincially.
I was also going to suggest something as easy as a bulletin board. You can see right behind me here, I have a bulletin board in my exam room, and it has advertisements for all different resources. And so literally, I don't have to say a thing when they're waiting for me, before their visit. I find a lot of people are actually, quite frankly, standing in front of that bulletin board or brochures, anything like that. You can pull the phone number off. It could be as easy as that, which actually takes almost no effort at all.
I just want to say, when we talk about specific resources to draw, I think there's many possible ways to see that, right? Like, I mean, if I think back on how we have built up our program over the last decade and a half or so, it really started with a few kind of local champions. And I think those were the first resource, like the people who were most passionate, which there were only a few in a large team, but there were enough to kind of start to just do everything from talking this up and building excitement to gathering community resource lists to educating others around it. We then started looking to much more specific resources, like actually creating positions in our team that specifically focused on these areas, right? Beyond the social workers who have a lot of training in this, as do others, actually dietitians and others are often quite knowledgeable around these types of issues. But like, we actually went to the government and said, we want income security specialists on our team, right, as health promoters. And we created that. We also looked, just even pushed that out more broadly and started saying, who can we partner with that has resources? And through that, for example, created a partnership with Legal Aid Ontario that was willing, and the Law Foundation of Ontario was able to fund a medical legal partnership within our practice, we were then able to get funding for like a community engagement coordinator, for example, right? Another kind of specialist within the team. Like it all just sort of, and we used bits of research funding sometimes, we used bits of community-based funding, some donations that came in, and really pieced it together slowly over time. You know, and along with just a lot of ongoing relationship building with community organizations and community members and patients, who really helped. A lot of this was again about just building space and building excitement for this work. And it happens slowly, right? And one of the things that I always like to put forward is like, and I think we've said this over and over, but you start with something small and then you just keep building little step by little step by little step and build it out. The beauty of it is that right now, I think as the existence of this conference is part of that, right? I mean, there is a huge social, societal excitement about this type of work. And I think there's very good reason for that. Like this is the time, I think, to actually be getting out there and saying, I need these resources in my practice and in my community to make this happen. You know, the struggle will be far less intense than I think it's ever been. Quite honestly, I think those doors are really opening.
Okay, let's see. Is there any surprising benefits you've noticed from social prescribing, something unexpected that you've seen in your practice?
I'm going to jump off from a comment I really like in the chat, that it's important for clinicians to know the expertise of the organizations they're referring to and build up relationships with organizations. That's been one of the most joyful parts of social prescribing for me, and that was actually a surprise, right? That as a doc working in a new community, how meaningful it would be to build these bridges, not just for the people that I'm caring for, but also for me to understand, you know, what's my community like? Who else is there? Who else is caring for people, maybe in different ways than I am. So I love everything about that comment. I'd share that as one of my early surprises here.
I think one of the surprises for me, which maybe shouldn't have been a surprise when I think back, but it also relates to a question in the comment in the chat that I'm seeing around medical schools and trainees. One of the pieces for me that struck me and kind of increasingly so over time is the incredible expertise in this area from the sort of newest practitioners coming in, right? And the way that, you know, I know for me personally, and I think others on my team, like I feel like we are constantly being pushed in a really good way, but in a often very critical ways to sort of look at what we're doing and say, is this enough? And to incorporate what I think are deeper and deeper understandings and analyses of like really of structures of oppression in society. Like that's more and more what I'm hearing from medical students and residents, pushing us to say, how are you dealing with this, right? How are you responding to George Floyd, right? How are you responding to truth and reconciliation? You know, how are you responding to these big movements that are happening especially in ways that are led by young people in society? And responding to challenges, again, what they're saying is that they see themselves as entering an institution again that is part of the problem or has been part of the problem historically, and pushing us to say, how will this not be part of the problem in the future? So, and I'm saying that partly to say that, like, you know, when we come to the question of how this builds into education, I actually think it's the students themselves that are building this into education far more than it is like me as the, getting old teacher is building this into education. But I mean, I have lots of examples where this has been added to curriculum. There's huge, huge transformation happening there. But really one of the ongoing surprises for me is the way this resonates with the youngest people coming into the profession, which is wonderful.
There's so much to digest. Like I'm processing as I'm talking. Okay, so if people are looking to engage some clinicians, what works? How do we connect with you?
One, make it personal, right? So I think having a friendly face to talk to about referrals and this kind of thing, it makes such a huge difference. And two, make it easy as well. I think of all of the docs that are and clinicians are so busy working in a health system that's so overwhelmed right now. And sometimes, you really just need to have open both the, the referral sheet and the phone line and the email and however you want to welcome people into the program and have them all open for clinicians to refer and then include the self-refer option as well. So make it personal, make it easy. I think that's really the bottom line for bringing clinicians on board into social prescribing or other social intervention programs.
I think it's important too, and you mentioned this earlier, Natasha, was the feedback piece. So I think if you really want the buy-in to be able to feed back to us that, hey, this patient attended this program and they're doing great. And we may eventually figure that out once we see them again. But it's so nice. I really enjoy that as a physician in getting that, I guess that happy ending or that positive feedback. And it just reinforces that so much more to, hey, this worked out well for this patient. I'm going to try it in this patient and this patient. So I think that's a very important piece.
And I love that. And I think it adds to the legitimacy. Again, not that social prescribing needs legitimacy, but it adds to the legitimacy that's similar to a regular referral. If you explore an option with someone, they end up deciding to pursue a social prescription, and then you hear back from the program with something like, okay, actually this person joined, this is what we worked on together, this is what you can continue to work on as their family doc. That's actually, I haven't seen a lot of that, but I think I'd love to see that because we do like hearing about the people in our practices and how they do these programs and how their health changes with involvement in these programs.
Yeah, I think, I agree with all of this. The only other piece I would add around how to push this out is to really push for this idea to become a normal and expected part of practice, right? Which is really, and then again, I think we're getting closer to that, but we're not quite, we're certainly not quite there. But I wouldn't love this, but I'd be amazed to see a college of physicians and surgeons put out a statement saying, if you do not address your patient's social needs, you are not actually performing to the standard we expect of primary care providers. And maybe that's controversial because no one likes the college putting anything out, but it's, it just, what I'm saying is that I just think this will at some point be seen as absolutely expected and absolutely normal. So I just wanted to put that forward.
Gary, again, I'll add in a spicy part of the conversation, just in case there's anyone from the college listening to this conversation. The flip side of accountability and expectation is support. So to do this, we need link workers connected to every single family practice in Canada. And without some kind of support, you can't really make it an expectation. That's just in case there's someone from the college listening or someone from government or decision maker listening.
I think that's really important. And sorry to jump in again here, but I wanted to use as a segue to respond to a question in the chat that is getting a lot of attention, which is around whether there are unexpected negatives of social prescribing, unanticipated or unintended outcomes. And I think that is really important to think about, right? And I think that one of the potential negative, there are a few that I would point to. One of them relates back to what I think we're saying here, which is that if you are, or that there is a fear and there's some legitimacy to this, that if you're identifying social needs that you are unable to address, I think there's really a fear that you may end up in a situation that is uncomfortable at best and maybe harmful at worst, right? And I think there's some literature to back there's been conversation in the literature that's sort of played around this idea for a number of years. I'm not sure I agree with that, but I think it is absolutely worth considering. But you have to be careful how you tread, and if you want to ask deep personal questions, you got to know where you're going to go with that. I think the other unexpected negative that I would just be cautious about, and this is something that's sort of talked about kind of more outside of healthcare circles than inside of healthcare circles, but it's this idea of the over medicalization of social situations, right? And it's often termed as like the medicalization of poverty, for example, where people say that, you know what, these are not medical issues, right? So it runs counter to a lot of the narrative we've been putting forward here. But I think this has been said many, many times to me, and I think even more times behind my back, that, you know, what you're trying to do is take a social issue and just pull it into this kind of hierarchical medical world where you think you can solve everything. And these are not problems that will be solved by healthcare. Right. And I think, you know, my counter to that has always been, well, I only see this as a sort of stepping stone towards deeper change. And I think that this will contribute to deeper social change. But if we don't keep moving forward, if we get stuck at that medical intervention point, then I think there could be some legitimacy to that critique. And I think we have to be very, very careful to kind of keep an analysis that is broader in our minds as we engage in this work, and recognize that what we are doing is one small piece of what needs to be done to really deal with health inequities. I don't know if anyone else has any other negatives. Those are the two big ones that kind of come to my mind.
When I thought of Gary was the intense, again, I resonate with this, the intense frustration that we can feel. And the thing that leads to burnout is knowing what the right thing to do is versus, you know, what the system supports, and that gap between that. I think that leads to a lot of moral injury and burnout in health professionals, and the intense frustration that we feel when we ask these questions. But what do you do about it? Right. And if we don't have supports like link workers, like systems navigators, like social prescriptions, to actually get to that next level of both asking and then having something practical to do about it.
And then just to sort of piggyback on that, I don't know if it's not necessarily a negative outcome, but it's just talking about the time factor, you know, especially in primary care. Time is so valuable, and you know, we all know we don't have enough time with the patients, enough time for paperwork, enough time for anything, and this takes time, and we've certainly talked about how, you know, we can make it as sort of quick and simple as we can, but let's face it, it does add time. So that's something that we have to figure out how we can incorporate that into our visits and be as efficient as possible to deal with all of the issues in a realistic amount of time for each visit.
The chat is fascinating. I'm going to have to ask for the transcript so we can review it again later. We only have a couple minutes left. So what if we end with a call to action, just like one closing thought or call to action that you'd like to share with the participants of our session today? It might be to overthrow the system. I'm hearing a little bit of that in the conversation. Just one final thought or closing thought or call to action.
Sure. I'm just going to reiterate my feeling of really meeting patients where they're at. The other thing we didn't talk about too much, but just also, trying to empower patients to become involved in their health and engaged in their health. So, providing that link and providing that social prescription but so to get them engaged as well.
Yeah, I think I would say, on top of, like, we've talked about so many things today, but I think the one thing I would add to that is find each other. Like, just build supports, build communities, find those people in your teams, in your communities, in your extended, health provider communities of practice. Find the people that want to do this work and ally with them and build support systems around this. So that you don't feel like you have to kind of tread fairly difficult territory alone, right? And I think that will allow us to really expand this work and to think together about what this should look like, right, as a collective, which I think is really where we need to go with this.
2 calls to action, very brief. One is, if you're a clinician or someone starting a social prescribing program, start where you are, use what you have, do what you can, right? And that applies across the board, regardless of setting. And then 2, if you're a decision maker, funder, government, listening to this, time is now. Teamwork makes the dream work. And social prescribing is really connecting health and social needs and building that team in.
Awesome. Okay, I was just going to say, like, stay open. The client journey might surprise you, because some of the social prescription journeys I've gone on with people really like brought the client somewhere I had could have never imagined, but it was just keeping the conversation going. And it might take like a few months or a few years for them to get to the place where they are really in a good place or have something really meaningful in their lives. But it's like step by step and just kind of walking that path with the client. That's my final thought. Oh man, we have such good questions in the chat. It's hard to end. It's hard to end. But I feel like correct me if I'm wrong, but I feel Jason, like we're at the end of our time pretty soon. Am I right, Jason?
Yes. Another show starts in 10 minutes, that's why.
Okay, so we're gonna wrap up here. Thank you so much, everyone, for your engagement with our panel, and thank you so much to the panel. Thank you for bringing like your insights and your wisdom and your humor and your stories to the table today. Thank you so much, everyone.